Welcome to GW Integrative Medicine, the podcast about disease prevention and health promotion from the Office of Integrative Medicine and Health at the George Washington University School of Medicine and Health Sciences.
I'm Dr. Leigh A, Director of the Integrative Medicine programs here at GW.
And I'm Janet Rodriguez, the office's Administrative Director. Today, we're going to talk with Janese Laster, MD, a gastroenterologist here in Washington, D.C.
Dr. Laster and I co-authored Beyond the Calories is the Problem in the Processing, a review of trends in dietary patterns, ultra-processed foods, chronic diseases, and mortality in the U.S., which was recently published in Current Treatment Options in Gastroenterology.
Board certified in gastroenterology, internal medicine, and obesity medicine, Dr. Laster's research focus is on nutrition and obesity medicine within the field of gastroenterology. A Nestle Nutrition Fellow, she's a member of the Obesity Society, the American College of Gastroenterology, and a physician nutrition specialist, diplomate.
Welcome to GW Integrative Medicine, Janese.
Thank you so much for having me. I'm excited to talk with you ladies today.
Yeah, this should be a great one. I think our listeners are going to be very excited about this topic.
I agree. It's definitely a hot topic, as it should always have been, but definitely a lot of buzz right now.
That's right. So what motivated you to get involved with GI and to incorporate nutrition in your patient care?
The love for GI initially started in medical school. I thought it had kind of the best of all worlds. My mom thought it was a little crazy, but I liked the bloody side of it with the emergencies in the ICU. I like the sort of mundane, kind of normal day-to-day things with typical screening colonoscopies and upper endoscopies, and then you get the clinic visits as well. So that's kind of, GI gives you a little bit of everything. And the nutrition portion came in during fellowship when I realized there were so many patients that we were seeing that I don't think we would necessarily get into the root cause of what their issues were. There's so much abdominal pain, constipation, heartburn. We see these things routinely, and we do the procedures for them, give them a medication. The patients continue to have these symptoms. And I started to realize, this diet history is likely a part of why you're having so many of these symptoms. And then I realized I am getting zero education during my fellowship about what I should be doing for these patients. I know how I eat, but that's not necessarily evidence-based. That's an N of one. So I said, I need to figure out where do I go from here? How do I learn how to be able to give patients some quality education to be able to help them more? So that's kind of where my deep dive into this whole of nutrition came about.
That story is wonderful, and I have to say, probably not that uncommon. I think when clinicians get into the field, they start to realize that, man, maybe some nutrition background would have been really helpful. So it's great that you recognize that and you actually pursued getting yourself the nutrition education you needed to better take care of your patients.
Oh, 100%. You get almost no education in medical school about it, and you're so focused on kind of the big sciences in medical school that it just gets pushed to the wayside, which I really think is unfortunate. The more that I've learned during my clinical nutrition fellowship, and the more that I've learned, and the more I'm able to take care of my patients now, I wish I was able to incorporate this so much more during my residency and fellowship. It would have been a much better tool to have. So.
Mm-hmm. So in your clinical practice, what are the most common diet-related issues that you see?
Let's see. I'll say maybe the big five are abdominal pain. Heartburn, constipation, diarrhea, and then the other question that people ask is about weight loss, of course, or trying to get weight loss. So those are kind of maybe the top five things we probably see in a clinical practice.
And would you see a number of those in one of your patients, or is it typically they're coming in for one real issue that they're complaining about?
Usually once we get to the root cause of it, it's a combination of things. Typically, I see a patient that has abdominal pain, and once we get to the root cause and rule out kind of what I tell them, the big, bad, and ugly things like the cancers and, anything or pancreatitis or anything with the gallbladder, once we rule all of those things out, we get down to it and we realize, you also have bloating, also have, early satiety. You also don't have good bowel movements, and those are likely things that are causing you to have that abdominal pain. And the reason you're constipated is usually because of whatever the diet it is that you're consuming. So people, normally no one wants to hear that because they don't want to change their diet. It's not the popular answer. It's really hilarious.
Well, it's not the quick fix, I guess, right?
No, exactly. And they want to peel. Sometimes it's almost as if they want something to be wrong, which is always funny. But, we make a joke about it, and, I tell them, give me some time, we'll get there, it'll all be better, and we all go kind of on the journey together and kind of joke along the way. But
so in your experience, what are some of the tips you would give to a fellow healthcare provider who might be just starting to get into the world of nutrition and GI diseases?
That's a good question. Actually, it's a little bit simpler now because there's so many conferences, and social media is a good tool as well. As far as Twitter and Instagram, there's a lot of the big name providers that are in those spaces. There's lifestyle medicine courses, there's obesity medicine courses, there the ACN courses, there are Aspen, which is a nutrition conference.
It's interesting. Have you been to Aspen? Mm-hmm. I am so impressed by that.
Yeah, I went. I presented last year. It was awesome.
Oh, that's fantastic.
Yeah,
I actually haven't been to Aspen.
Really?
I've been to the Maryland version of Aspen, but not to the nationwide one. It's on my to-do list.
It's an awesome conference, and two of my main mentors from the Nestle Nutrition Fellowship are huge in Aspen. So Steve McClave and Bob Martindale are kind of the famous old guys that everybody runs to and flocks to. So they encouraged all of the Nestle Fellows to go.
That's fantastic. That's good to know. And it's good to know that it appeals to a clinician who maybe doesn't have the nutrition background. I always think of it as being a very dietitian-centric conference.
It is. And we were trying to get them to do a couple of more things that may be a little bit more physician-centered to kind of gather some more attention for physicians, to get them a little bit more involved so they will incorporate it more and to see the value of dietitians and, to kind of being in your practice, especially in a GI practice. It's a huge, huge value to have somebody that can give them that one-on-one time that you may not have as a gastroenterologist.
Absolutely. That's definitely one of the things we talk about with integrative medicine, team-based medicine, and knowing when to refer.
Yes.
You can't possibly know everything. So speaking of that, what would be an indication you would typically refer your patients out to for a dietitian? Is there anything specifically you're utilizing a dietitian for that maybe others could also be doing in their practice?
Let's see. I may be a little bit different because I have the additional training,
Right.
and I do spend, a lot of time in that area. But one particular thing that I find to be really important is when somebody has a true diagnosis of celiac disease, and I mean biopsy proven, proven by serology, not just you have a little bit of bloated if you have a gluten. I meant real celiac disease. And so those patients, I feel, really need to sit down and have detailed understanding of what is in gluten and how to not have any things to mix in. Because there's sometimes things that are very subtle. Or I had a patient that is Italian, and we couldn't figure out why he would relapse. And he finally told us, well, I do so well Monday through Saturday. And we so what happens on Sunday? And he goes, well, I eat at my mom's. And I'm like, so what does your mom cook? He goes, she's Italian. We have pasta. And we're like, well, you just throw out everything out of the window that you just did Monday through Saturday because your inflammation starts back over again. So these are people that really need a dietitian to go through those packages of crackers that I see lurking in their bags when they're in the clinic. And I'm like, that's gluten, So these are things that I know we kind of skim over in our clinics, but with a dietitian, I think they do a really good job of getting people to understand what is gluten and why we care so much about them not being, getting those contaminants.
Yeah, thank you. That's very helpful. I think both Janet and I are well aware that gluten hides in things.
Yes.
And when you're new to this, it's extremely overwhelming. And if you had someone to guide you, wouldn't that be so much easier?
It would, because somebody could warn you about soy sauce.
Right.
Yes.
the little things like that you just don't know until you can't figure out why every time you go out for sushi, you feel terrible. Oh, maybe I have another food.
Is it the third
allergy.
or fourth ingredient in soy sauce is wheat? I forget which.
I can't remember, but it's it's in there, but it's pretty far down. So if you just glance at it, you might not see it. Yeah, that's definitely where a dietitian or even a like a certified nutrition specialist health coach could really come in and help you find those things.
Oh, yeah.
Now, I was really excited when your article was published. So this review you wrote, what sparked that? How'd that come about?
I think it got sparked from a talk I did at Aspen last year, actually. During this nutrition pathway, I kind of went down a deep, dark hole of trying to understand more about processed foods and what made foods processed and what was in them. And I started learning more about emulsifiers and additives, and I did a talk on that at Aspen that kind of made everybody go crazy because they're in everything. And I found the kind of a correlation about kind of when we started to become more of an industrialized country, it kind of correlated with increased autoimmune diseases and increased processed foods and having things that were more convenient. And that's kind of where it came from for me. It's kind of going down that hole and figuring out, we have a lot of processed foods. And initially they got approved as generally recognized as safe because of some issues with the FDA in the 90s when it was taking a long time to get things approved. And realized at that point they started putting them in everything, and they're so kind of ubiquitous in our condiments and our in our foods. So we're getting a whole lot more than we were back when they initially were approved for consumption in like the 50s. So that's kind of where it started. And then
don't you think that's part of the issue, perhaps? Maybe it is generally recognized as safe in very low doses, but when it's in everything and you're being exposed to it at every meal, and that's when we're really seeing a problem. Exactly.
If you don't mind my asking, can you explain what an emulsifier is?
Sure. An emulsifier is basically a substance that's put into a food to make something shelf stable, something to make it be able to preserve. So back in, the early days, salts were things to kind of make things stable, to last longer, and to cure meats and that sort of thing. But when you fast forward to today, it's kind of in mayonnaise. So there's also things to kind of keep things together, to keep them from separating. So oil and, water to keep things congealed. So salad dressings, things like that. They also make things stay more stable on the shelf for longer periods of time, keep them fresh, keep the color, make them taste better. So they're stabilizing agents in a sense. And they're kind of everywhere and in everything.
So is it always oil and air, or oil, water, and salt? Or is there other things that they're using that people may not realize are not necessarily good in this form?
I don't think repeat the question?
The emulsifiers, are they always just oil-based?
Oh, no. So emulsifiers in general, they kind of fall underneath this category of an additive. And so they can be anything, like something to make things not foam, to bulk things, like food color agents, stabilizers, preservatives, things that are thickeners, even sweeteners. They're all kind of fall under the category of an emulsifier. And normally they contain like a hydrophobic and a hydrophilic component, so that if you have that water and kind of lipid fraction and you allow these things to kind of mix, so something that was otherwise unmixable, these things help to make them stay together, to help increase that shelf life, to enhance the flavor, kind of make the texture better, and prevent things from dispersing. So it makes them look better. If you had a thing of mayo without those emulsifiers in them, it would look gross and people wouldn't want to eat it. So that's kind of what they use it for. Think of fruit snacks, that gelatin and fruit snacks that keep those things together so we want to eat it, and so it tastes good when we eat them.
And it really is about how long it's shelf stable, right? Like that mayonnaise would be fine for a couple of days, but since it's been sitting on the shelf for a couple of months, now it's starting to separate and look gross.
Mm-hmm. Exactly.
Yeah, maybe things shouldn't sit on the shelves for years. That might be the problem.
Exactly.
So as the authors of this review, can you tell us a little bit about why they're bad for us?
I can start. And so where this initially came from was I looked at a bunch of preliminary studies kind of in mice and in kind of human models to see kind of what was happening when, what did our bodies do with these emulsifiers. And some of the things that I found were pretty interesting. So first of all, our bodies simply don't really know what to do with some of these emulsifiers over time, as far as in our small bowel. And as a gastroenterologist, this is what I look at in patients with inflammatory bowel disease. So you start to see these micro breaks in the mucosa, which allow bacteria to kind of be able to sneak into your system because it kind of breaks down the good bacteria that you would have in your small bowel, decreasing the mucin layer that you have in your small bowel as well, so that it allows things to break through it. And so when you have that, you think of that as an inflammatory response. So if you scratch your hand and it gets red and you starts to get puffy, that's an inflammatory response, right? The same thing happens in your small bowel. So on a small level, that's kind of what's happening with these emulsifiers when your body has no idea what to do with these agents. And so what was interesting to me was what was being found in some of these mice studies is this was causing an inflammatory cascade, which was leading to metabolic syndrome, and the mice having fatty liver, and the mice having increased high blood pressure and elevated blood glucose and lipids. And so that's what was interesting to me about when I first started to look more into these emulsifiers. Granted, we've not been able to, do this in human studies as of, well, not technically. There was a trial recently done by Kevin Hall that we discussed in our paper, but so that was what was interesting to me, because that kind of went along with my hypothesis in the beginning that increased processed foods also cause you to have these increased risks for metabolic syndrome, meaning obesity, high blood pressure, high cholesterol, and diabetes. And that was one of the things that kind of prompted us to talk about this a lot in our paper and kind of in a human model.
That is fascinating, and it just tells me that you working with Leigh is just a match made in heaven.
That it is. We are very much we keep turning up together in spots we didn't even know it was going to happen. We are on the same track.
We first met and we had lunch together, and we literally were finishing each other's sentences. That literally was a match made in heaven.
That's true. And that's another social media win. We actually really officially met over Twitter.
Yes.
And then we were like, let's have lunch because you're right around the corner. So yay, social media, med Twitter.
Definitely. And I was new to Twitter as well. And I was like, maybe I'll try this thing out. And I was like, oh, it's great, actually. I met a perfect person for me at GW. Who knew?
I was teaching the PA students yesterday, and I told them all that they need to get on Twitter because it makes keeping up with the science so much easier.
Yes.
Because, like, for instance, when Kevin Hall's study came out, I heard it from Kevin Hall on Twitter when it came out, right? I didn't have to go and look up the study or wait till the announcement came out. And my whole network was retweeting it because we all want to hear that type of thing. Mm-hmm. And I think it kind of blew their mind a little bit, actually. They never thought about social media in that way, probably because they grew up with it and it's not a foreign concept to them. But to change the way they looked at it. And all of them afterwards were like, wait, what's your handle? I'm going to follow you. So I hope I converted them.
Yeah, Twitter has been awesome for that. I find out about so many studies, and I found out about the lifestyle medicine course and the conference through there. Like, it's awesome. You see things when, you get to follow Dean Ornish and, Caldwell Esselstyn. These are all like my heroes, and I get to follow them on Twitter and see what they're thinking about the new articles that come out if they agree with what I think. So it's pretty awesome.
Yeah, that's true. You're getting a different take on the articles than you just sitting down and reading them.
Of course. Yep. From the author, from the horse's mouth. It's awesome.
So what can you tell us about your ongoing research?
Let's see. What do I have going on? I am in Madrid right now, and so my brain is all over the place. One of the things that I've been looking at recently that Leigh and I talked about is one of the interests that I have is microbiome and kind of how those things are being able to be changed by diet. And one of my other thoughts was that, we know in studies from the past that there's microbiome changes in patients with obesity versus lean patients. And this was also it being able to be seen in replicated in these emulsifier studies as well. But my question was, is it the chicken or the egg? Is it the fact that you already were predestined to have problems with excess weight, and that is what affected your microbiome? Or is it the diet that changed your microbiome that made you the propensity to have obesity? And which one came first? So one of the things we were trying to determine is how quickly can the microbiome be changed by your diet, and whether that will affect your weight. And so what we were doing is getting pre-samples of people's stool, essentially, to look at their microbiome, which is in its early stages, so it doesn't tell us everything just yet. But I think in the future, this will be hilarious to us, because it'll be like, yeah, you silly people didn't know what this meant. But looking at their pre-microbiome and assessing their weight and other things, all the things that can kind of change your microbiome with a survey, such as, if you were breastfed, if you were born by C-section or vaginally, if you're on chronic antibiotics, chronic steroids or hormones or head cancer, a host of other things, and looking at that microbiome beforehand, and then giving them kind of a dietary intervention, which we know can change the microbiome rather quickly. With the Mediterranean diet, and then checking their microbiome again after said intervention to see if there's a change in weight or a change in the microbiome to kind of a more favorable microbiome.
And how long are they on that Mediterranean diet?
2 weeks.
2 weeks, okay.
Yep.
So that's very reasonable. You're not asking a ton from your patients.
Exactly, because we know how compliance is, and so 2 weeks is all we're asking. So that's what we're trying to look at now.
Yeah, you should definitely see some changes in 2 weeks. It'll just be interesting to see how quickly it goes back, if it does go back.
Oh, yeah. It will go back quickly as well. But if you can get them to kind of, the hope is that we get them to see some light during that tunnel, and to feel less bloated during that time, to feel less pain during that time, to actually be able to have a bowel movement during that time. It's amazing that people don't believe that, yes, if you haven't had a bowel movement in 2 weeks, that tends to hurt. Yes, you tend to feel a little bit bloated. Yes, you don't feel hungry. You feel nausea. And they all come to clinic with these exact same complaints, and I finish their sentences, and they think I'm really smart, but I'm like, no, it's pretty simple, actually.
Yeah, you've just seen patients like this over and over again.
Yeah. I'm like, you're number 6 today, so... With our American diet, you're all eating the same.
Yeah, it's okay. True. Well, I'm glad you're out there helping them learn the light side, bring them to the light side, away from the dark side of the sad American diet.
It's really nice when someone kind of trusts you and says they're going to give it a try. I think most of the time they've reached kind of the end of the line, and they're so sick of being so fatigued and having that fog and having pain that they're willing to try anything. And they're like, okay, fine, we'll listen to this crazy person and see what she says. And it's funny when they come back, they're almost annoyed with me when they come back and it worked. It's really funny. Like you walk into the room and their hands are crossed, and I'm like, oh, here we go. She's going to be upset with me. And she goes, it worked. I feel better. And I'm like, well, that's great, right? And she goes, but now I can't have anything. And I'm like, yes, you can have plenty. I just don't want you to drink, 2 liters of Coke a day,
Right.
You can have plenty. So it's funny. It's always like a hilarious conversation when they actually feel better. Because none of them believe it's going to work at all. None of them believe simply having a bowel movement is life-changing. So,
well, it is a really important part of being alive. We all need to do it. Yeah. Absolutely.
So it's funny. And another thing you and I agree on is fiber intake.
I was just thinking about fiber too, speaking of bowel movements.
Mm-hmm. And so I kind of talked to him about how fiber helps with the short chain fatty acids, and also helps to kind of help with your microbiome and how you utilize calories. And so it's a difference in how, depending on what you eat, how your body is able to metabolize those calories. So you're better able to handle what you consume and not put on excess weight the more fiber you have. So you're actually able to eat more. And so it's funny because a recent friend's sister from Texas, the land of all things meat, I've forgotten to get off of said meat. And she called me like, I have lost 12 pounds since we have spoken, and I cannot believe this. So it's funny once they buy in and once they start to see it, then the momentum really starts. So that's the nice part when they come back and you see a light. Mm-hmm. So
that's great. What are some of the things I know you said that they're kind of coming into you and they're like, oh, I've tried everything. But do you have any other tools that you use for motivating your patients that maybe some of the other healthcare providers who are listening might be able to try?
I think one of the things that I do is I acknowledge that it's hard. I acknowledge that it's time consuming. I acknowledge that it's a habit that we form your entire life. If you come to me and you're 50 years old and this is what you've done your entire life, it's very difficult and it's daunting to think about kind of changing that lifestyle. And people always say, I've been doing this my entire life. And that's their mindset, and that's comfortable. So it's hard to change habits. So I think that's one of the things that I start off with. And I also make slow changes. And I meet people where they are. If I don't tell people to, wake up one day and to completely be vegan and, plant-based and no drink only water and don't, you have to meet people where they are and try to work within things that they like, first of all. I'm not going to tell everybody to eat black beans. If you may not like black beans, and that's okay. There's many other beans that I can try to get you to eat and mix into things. So I think that's one of the things, too. I think some people get frustrated and say, people don't have willpower, which I don't think is true. I just think that people don't know. There's a lot of things for you with a PhD, for us that's gone through medical school, there's a lot of things that we take for granted that we learned, that our patients, these are, we think they're simple, but for my patients, they are writing down every word that I say. And I'm like, I'll write this down for you. I want you to just listen right now. We'll give you a handout. But so that's kind of where I start slowly and I follow up often. And I start with slow steps. I think those are things. I think is listening to them and listening to the struggles they've had, I think is important. And kind of just being able to understand that somebody that finally understands them doesn't judge them. And I don't. I just tell them, this is hard. I didn't start eating this way overnight. I tell them, and I always joke around. I'm like, I'm from Birmingham, Alabama. It is the land of all things fried and all things are soaked in butter. And so if I can turn it over a healthy leaf, then, anybody can. Because I grew up eating fried chicken and macaroni and cheese, and these are things that are staples. And, I don't even have an urge for them anymore like I thought I would. So
yeah, your tastes have changed.
Process. Exactly. And I tell them that too. And I also kind of talk to them kind of on a scientific level. I'm like, when you tell me that you can't live without your Diet Coke, that's kind of true in a sense. It's not you necessarily that can't live. It's your microbiome that wants to live. And those suckers want to live. And so, yeah, they make you feel like you cannot live without the soda. That's sort of true. I was like, so we have to slowly kill off those guys with beans and kale and spinach and and get rid of those so your body craves for you to have a salad instead of craves that soda. And they can't believe it when I say them. I'm like, but I'm like, I promise you, when I'm on vacation and I'm eating, fried cauliflower, because that's like the, plant-based junk food or, something like that, then after about a couple of days of that, I am starved. I'm craving a salad. I was like, I promise you it's true. You get there.
It is true. I actually was recently on my honeymoon, and every day for lunch I had a salad because that's what I really wanted to have after eating the rich food for our wedding, and then even in the evenings having a bigger meal. I was like, oh God, I just need a nice, light, refreshing salad. Plus I was on the beach, perfect.
Exactly.
Beach wet food is salad. That is all the time we have for today, Janese. Thanks so much for joining us.
Awesome. Thanks so much for having me. This was awesome.
This is the GW Integrative Medicine podcast from the GW Office of Integrative Medicine and Health.
I'm Dr. Leigh Frame.
And I'm Janet Rodriguez.
Thanks for listening.